All right, this is chapter 36, patient with special challenges. Remember that this is not all inclusive of patients with special challenges, and the special challenges are some of the things that we have to consider. Our whole profession is so dynamic that we're always changing, and we have to adapt to situations as they present themselves. The biggest thing is to make sure that you're educating yourself on what's going on, and you educate yourself on the latest trends. So I've got a couple videos that I'm going to show during this PowerPoint presentation, and then I'm going to add additional videos. I think I'm going to add it to the drive so you guys can see those as well. All right, so when we talk about patients with special challenges, the big thing is understanding that mechanical devices can be present, and being at least somewhat familiar with mechanical devices. Don't get distracted by the fact that these patients have pre-existing conditions that require medical devices. Make sure you're treating the patient and what's going on today, right? And then being familiar with what your capabilities are within your scope as well when it comes to this sorts of patients. So we start with disabilities, developmental and intellectual disabilities. Some people have developmental disabilities where they don't cognitively develop past a certain age, or they could just be delayed in development and they catch up through therapy and behavioral therapy and occupational therapy. Intellectual disability, these are people who have stopped developing and they're unable to develop the cognitive skills, the social skills, or the skills to work through the activities of daily living. So depending on the inability or the impairment, these people may or may not have an appointed guardian for them. Remember, anybody under 18 falls under the parent, or there's a caregiver, whoever has that responsibility. The people over 18, they'll have a court-appointed guardian. If they're inhibited on making decisions for themselves, if there's communication barriers, things like that. So it's important to establish that as well. But even if there is an appointed guardian, you need to make sure that you're talking to your patient and trying to communicate with your patient as best as possible too, because your patient can give you some of the best information. All right. So talks about relying on patients and family members, also caregivers that are on the premises. Sometimes people have home health. Sometimes people have home health that it changes from day to day, but there should be a log where home health has kept notes throughout the month of what's been going on with that patient. The big one is ask what's different today, what brought you to their house or the facility that you're at, and make sure that you're assessing the patient. Get a normal baseline, and then use that, what their patient's baseline is, to measure against today what the baseline of your level of consciousness and what's going on. Make sure you document what their normal baseline is. If it varies from alert and oriented ×4, document what their normal baseline, maybe mobility is, those sorts of things. And then document if there's some sort of communication obstruction for one reason or another. That needs to be part of your documentation. All right, spectrum disorders. So it talks about the autism spectrum. We refer to it now as primarily the spectrum. Spectrum disorder occurs more often in boys than girls, although we can have both boys and females and males can end up with spectrum issues. Some of them are severe spectrum issues that encompass a wide range of symptoms. Some of them are just very specific symptoms that fall under the spectrum range. So it's important to find out, again, how that patient normally communicates. Don't get into somebody's bubble when they have spectrum issues, and making eye contact or forcing eye contact with somebody who has a spectrum issue can really inhibit or create a big barrier for you when you're trying to communicate with them. I know we talk about communication and making eye contact with your patients. This is one of those times that making and forcing eye contact with somebody might not be the best. Communicate with your patient though. Don't force yourself into their bubble, but also, talk to them, don't talk down to them. You need to make sure that you are addressing the patient at the cognitive level that's appropriate. Right? And then of course, asking caregivers that are on scene. All right. So when we're following directions again, or giving directions, simple one-step directions as part of your assessment, try and have your questions be those close-ended questions, at least to start with, when you are gathering information. And then that can open up for the wider range of questions that have answers that are involve more complex communication skills, I should say. Not complex thought. People with spectrum, a lot of times their IQ can be very, very high, but it's just expressing what they want to say in a way that they feel you'll understand it. Down syndrome. So patients with Down syndrome, this occurs in fetal development. And with Down syndrome, the patients it's usually diagnosed while the patient's, while the baby's still a fetus in utero. The Down syndrome comes with a large array of connected kind of issues to it. Patients with Down syndrome, they'll end up having a rather flat occipital region on the back of their head. Their tongue is going to be much larger, which creates airway issues, especially coupled with the back of the head. With little kids, we pat under their shoulders, right, to bring their head in the right position because they have that round occipital region. With people with Down syndrome, if we're having to control the airway and manage an airway in somebody with Down syndrome, you might have to do the opposite. And then you have to compensate for the tongue, right? Their eyes tend to be wider apart and they tend to be more slanted. The jaw, and because of the structures of the airway in the jaw, it might be harder to control the airway and maintain an open airway, and you might have to use a jaw thrust maneuver even if there's not signs and symptoms of trauma or indications of traumatic injury. The jaw thrust might still be the way that you have to hold that jaw open because of the shape of the face, the mouth, and then the larger tongue to get a good seal on their face. And then increased medical risks and complications for people with Down syndrome, vision issues, hearing issues, congenital heart issues, and then sometimes even seizure issues. People with Down syndrome, though, are a normal part of our community. There's people with Down syndrome that live very long lives, they get married, and they're working in jobs in our community. So don't go into a patient's assessment assuming that somebody with Down syndrome is unable to communicate or is cognitively impaired. You need to assess what their cognitive level is. Communicate with that patient, but also with the family member or caregiver if they're present. Okay. All right, at the top here, I hate this bullet point. It's probably my least favorite in the entire chapter, or the entire book actually, that it's normal to feel uncomfortable in patients that have some sort of disability. That is 100% on you. If you're uncomfortable, it's your lack of education on the subject, as far as I'm concerned. Patients are patients, right? We deal with patients. We need to make sure we're able to treat the situation. Your comfort level comes with your knowledge, and that comes with pediatrics. Some people are uncomfortable with pediatrics. Again, that's your knowledge base. And people with disabilities. People that have Down syndrome, we'll talk about cerebral palsy here in a minute. People with that have intellectual delays, they wear their disability on the outside. Not everybody does. So just because we can see that they have a disability does not mean that we should be uncomfortable with it and that that's an okay, normal thing. My niece has cerebral palsy, and she is severely handicapped because of her disability. It's the only way she's ever known how to be. It's much more important that we explain to people what the differences are and we educate them, because that makes everybody more comfortable in the situation. So educating yourself is really, really important. Ask questions, ask caregivers questions, ask your patient questions. That's totally acceptable. You're learning and you want to make sure that you're providing the best care you can for not only this patient, but any other patient that comes after them that have similar disabilities. Make sure you introduce yourself just like you would with any other patient. Tell them what you're going to do before you do it. And then watch for people protecting their bubble, right? Communication's the biggest part though, making sure you're communicating with your patient. Patients with brain injuries. So there's a lot of different ways for somebody to have a brain injury. Some people are born with brain injuries. We'll talk about, again, cerebral palsy is just one of them, or people can end up having brain injuries after a stroke, after a traumatic injury. So that can change that person's everything from their personality to their ability to put cognitive thoughts together. And it's at different levels depending on what that patient, specific to that patient, what their limitations would be with that injury. So make sure you establish, again, the normal baseline for this patient. Document patient's baseline is such and such, and what's different today, all right? making sure that you're careful to document those things. Because remember, if we don't have somebody to tell us what an established normal is for this patient, we go under the alert and oriented ×4 with a GCS of 15, all right? Now, while their established normal baseline might not be alert and oriented ×4 with a GCS of 15, okay, we can document that their baseline is alert and oriented ×3, and then, you know, maybe their GCS is at 12 or 11, and document where there's the deficits, and that this is per caregivers the established normal baseline for this patient, right? And that way we have kind of a continuity of care, and we can paint a better picture, because that's our whole job, is to be a detective. All right, visual impairment, we talked about this again with geriatric chapter and in a couple other chapters. Patients who have visual impairments, it can be any range of visual impairments. Some people just need glasses to correct their vision to the point that they can see. Some people are considered to be legally blind without their glasses, or even with glasses. So it's important to establish what their normal level of vision is, and then go from there. So some people can see outlines of shapes. As we get older, the rods and cones in our eyes that help us to determine shapes and colors, they change with age. So it's not abnormal for people to need reading glasses when they get older, all right? So establish what their normal level of visual impairment is. And then again, just like you would with any patient, explain what you're doing to the patient or what you're planning on doing, get consent. Don't just start grabbing for things, all right? If somebody can't see you, then make sure you're making them aware of your position around them all the time. Eliminating background noises is important even with a visual impairment, because it can eliminate confusion. Yeah, there are visual issues, right? But if you've got stuff going on in the background, and this is an environment where it's stressful for that patient because this is not something that's an everyday thing for them, you eliminate that background stimulus, it helps you have that better communication with your patient. If you move things in the patient's house to gain access, make sure that somebody moves them back, because when they're brought home after their trip to the hospital, you don't want, one, the patient to have to move heavy furniture that you guys moved, or two, you don't want them to hurt themselves because things are not in the arrangement that they expected it to be. If the patient's being transported, again, if they have assistive devices like a cane, a walker, make sure you take those with you. If they have service animals, make sure that they have arrangements of how that you're going to take care of, what's their plan to take care of that service animal. If they had to have been transported or had an emergency to the hospital. And then, you know, don't just start grabbing on people to move them. Tell them what you're going to do. Make sure everybody is aware, you know, and that you're notifying the patient, you know, if we're going to lift you up, we're going to grab your knees and your elbows or grab you under your arms, and we're going to help you move over, okay? And then, you know, ask them what they're comfortable with as far as movement as well. Hearing impairments, again, people can have varying levels of hearing impairments at any age. I'm realizing now with this COVID stuff going on that I read lips a lot more than I used to, and everybody's wearing a mask. So it's harder to tell what somebody's saying when you can't see their lips under the mask, and it muffles the voice. So that can be one of those things that we're going to have to navigate through, because I don't want to remove my PPE necessarily, but I want to make sure that I can communicate with my patient, right? What are clues that people are having a hard time hearing you? Maybe they're turning their ear closer to you. Maybe you're saying things and they're not registering that you're talking to them. So getting in front to the patient's level, making eye contact if you can with that patient, eliminate background noises, and only have one person communicating with that patient is a good idea, all right? Some patients have hearing aids. Make sure that, you know, if they have a hearing aid, you're asking them if they have a hearing aid, if where it's at, is it turned on, you know, those sorts of things. If you're going to get their hearing aids, you know, if it's husband and wife, make sure you're grabbing the right hearing aids. Also, part of my documentation includes the patient had their hearing aid in place or their assistive devices, regardless of what they were, with them at the time of patient transfer to the hospital. That way, if things disappear, go missing, or they lose something, they can at least go back and figure out when was the last place it was seen and kind of retrace steps to look for things like hearing aids, which are really expensive, like canes for people, those sorts of things. That's always part of my documentation on my narrative. So in a minute, we'll show you some pictures of some hearing aids. Some of these are pretty outdated. It talks about using sign language. I would be very careful with that if you don't know what you're actually signing. Also, if the patient knows sign language or not, that's important as well. But if you use a sign language interpreter through a family member, it's documented that family member was interpreting via sign language when you were interviewing your patient. Sometimes there's a language barrier. If there's a language or communication barrier at all, that's also part of my narrative, regardless of what it is. Language barrier, something that inhibits communication with this patient, okay? And then you can also use if you have an extra stethoscope, the reverse stethoscope. So you give them, I don't like people putting my stethoscope in their ears, but clean off, if you have a spare one, let them wear the stethoscope and you can talk, don't put it right up to your mouth, but you can talk and see if they can hear you better with the stethoscope. That's just one way, one technique that can be used. All right, so there's different types of hearing aids. There's ones that go behind the ear. There are ones that go in the ear canal. My mom has one that hooks to a bolt in her head, and the bone in her head actually resonates the sound, and it uses her Bluetooth on her phone. So there's just some pictures of simple ones, depending on what's going on with that patient. Make sure that you're documenting, again, that they have a hearing aid with them and that's the right one. If it's making a high-pitched buzzing noise, it's a good chance the patient can't hear it, but we all can. That oftentimes means that their volume is up too high or it's not inserted all the way into their ear properly. All right, cerebral palsy. So this is something that's true to my heart because I do have a family member that has cerebral palsy. So cerebral palsy is actually a brain injury that occurs. And it's characterized by people, there's a group of symptoms that kind of fit under the cerebral palsy umbrella. So patients who have cerebral palsy might have underdeveloped limbs. They might not have coordination in their movements. Some people with cerebral palsy can be blind or partially blind. They can have associated seizure disorders with it. They can have hearing disorders that goes with the cerebral palsy. Some people who have cerebral palsy can't control their airway very well. They aren't able to move the muscles of their tongue very well, so they're at high risk for aspiration. So we really have to find out what the level of development is and how bad their cerebral palsy is, what deficits their cerebral palsy has caused. You can have people with cerebral palsy that are walking around next to us. I actually have one of my very good friends has cerebral palsy, and you wouldn't know it unless he tells you this. And he's actually one of the people that's introduced me some of the resources for cerebral palsy. So he's had many, many surgeries, occupational therapy that allows him to, what we see on the outside, we wouldn't recognize as the textbook cerebral palsy. Don't assume that people with cerebral palsy have intellectual disabilities or delays, although some people do. My niece is severely handicapped with cerebral palsy, so she does have developmental disabilities, and her cognitive development is about 4 years old, and she is almost 16 now. And she is nonverbal, and she is unable to really walk without a lot of help. It just totally depends on the individual and the level of damage to their brain before they were born. Right? With cerebral palsy, people who walk, their gait can be off, so more prone and more likely to having falls. Some of the muscles sometimes are too tight, or they might have ligaments or tendons that are too short. And just through physical therapy and intensive physical therapy, some of those things can be worked out, but not all of them. They will have assistive devices. Sometimes they'll have, in their shoes, they'll have braces that help put their foot in the right position when they try to walk. Same thing with their hands, help put their hands in the right position when they try to walk. Some people have in their wheelchairs so that they can sit back in their wheelchair in the right position. It just totally depends on the individual. Make sure though that you take their assistive devices with you, especially if you're doing your assessment on a patient and remove some of their braces. Make sure that those braces go with them to the hospital. Try not to cut the straps that come with the braces because they're super, super expensive to replace. All right, I'm gonna switch screens on you here, and I am going to show you a video. It's like one of my favorite videos about people with cerebral palsy.
The Cerebral Palsy Foundation asked me to help them promote the show Speechless by giving a list of my top 10 things I wish people knew about CP. I don't really know if I can come up with a list of 10 things, but I'm gonna try. Okay, number 1. Just because I'm in a wheelchair doesn't mean that you can pet me like a dog. I'm not a dog. And I know it seems nice and I'm at dog height, but that doesn't make me a dog. And just because I like to pee outside sometimes, that doesn't make me a dog. And just because I won the Westminster Dog Show last year doesn't mean, oh my God, am I a dog? Number 2, I think it's pronounced cerebral palsy. I don't know if cerebral is a word. Number 3, it is hard for people with cerebral palsy to make lists with their fingers, so I'm gonna stop doing it. Number 4, if you ask me what's wrong with my legs, the real answer to that is nothing. I have brain damage, so that's a little bit more exciting. Cerebral palsy isn't like, oh, that means your legs don't work. Some people with cerebral palsy are walking around just fine. Number 5, just because I have cerebral palsy doesn't mean I'm inherently inspiring. I'm inspiring because I'm an author, a YouTuber, and I have the biceps of a Greek god. Number 6, even though I have cerebral palsy, I still consider myself incredibly lucky. I have a great career, I have wonderful friends, and somehow I've managed to make a living while not getting up before noon most days. Number 7, just because your grandson has cerebral palsy doesn't mean I know him, Ethel. I mean, we don't even live in the same state. Number 8, yes, I'm gonna need some help with some stuff sometimes, but just talk to me like I'm a normal 31-year-old guy who's spilled a carton of chocolate milk on himself. Number 9, you are welcome to pray for me if you want, but I feel like having cerebral palsy is part of the reason I'm supposed to be here, and one of the tools that I can use to help people be a little bit more compassionate and open to people with differences. So it's just, I'm working with what I got there. And number 10, and most importantly, almost everything I've said is subjective, and you should just talk to more people with CP and see what they feel about it. Because I'm not a spokesman for all people with CP. People with CP are as diverse as all of humanity. So just go out there, have a conversation, and do what you can to educate yourself. So that's about.
All right, back to sharing my screen. Okay, so I think that video is actually incredibly important to watch when we're talking about patients that have cerebral palsy, and it sums up everything better than I could ever say it in any other way. All right, spina bifida. So this is when the spinal column doesn't completely close when the fetal development is occurring. And so the baby is born with part of the spinal column exposed. There are surgeries they can actually do in utero now where they can go in and try and close up the spinal column, but there are a lot of issues with that in and of itself. So patients that have spina bifida, a lot of times they're going to be paralyzed or partially paralyzed. They're going to be unable to control their bladder or bowels. And then they have this thing called hydrocephalus. So that's where there's an increase in fluid around their brain, and they'll require a shunt to go in and relieve the fluid out of their brain and then drain it down into the abdomen. We'll talk about shunts in just a minute. The other kind of unique thing about spina bifida patients is that they have this extreme sensitivity to latex. So some of our older birthing kits have latex gloves in them. The sterile gloves are still latex. And you want to, I say, throw them away and make sure you replace them with nitrile sterile gloves. But you want to be very careful because using those when you have a baby, delivery, a pre-hospital delivery, that patient, if they're allergic or if they have a baby that's allergic or born for some reason with spina bifida that was undiagnosed in utero when the fetus was developing, like say in a woman who didn't have any prenatal care, that can put them into anaphylaxis, and that just complicates your issues at that moment. All right, paralysis. So patients with paralysis can have paralysis for a lot of reasons. It can be due to a brain injury. It can be due to something like spina bifida, or it can be due to some damage they've had to their brain or to their spinal column and has subsequently caused paralysis. Remember with the cervical spine 3, 4, 5. So if those cervical vertebrae in the spine is damaged, the spinal column is damaged up in the cervical spine, we run the risk of having the diaphragm not work, right? So we tend to see dysfunction below the level of wherever that spinal column is and whatever the plexus and nerves that reach out from the spinal column at the level of the damage. We'll see disability below that level. So some patients who have paralysis, they're unable to swallow on their own depending on where that level of damage occurred. They might be on a ventilator at home, so they're unable to move their extremities or unable to move their extremities a whole lot. The diaphragm doesn't move on their own. They might have like urinary catheters or colostomies or G tubes, depending on what's going on and how the paralysis has affected their body. And then they might have no sensation where they're paralyzed or hypersensation when they're paralyzed. It just depends on what's going on. So when we have a patient that's paralyzed in a non-emergent situation, ask them how they normally move and help them, all right? Patients who are paralyzed are also at higher risk for bed sores and skin tears. So be very, very careful with these patients, especially if they don't have a lot of help with somebody moving them. Even when they do, they can end up with bed sores pretty bad. So ask them how they normally move, how they would like you to help them move. Those are questions instead of just going and trying to move the patient, right? And then be very careful with their extremities. They can't move their extremities. So you want to make sure that they don't get caught. You've got somebody that's there to lift the extremities over and that it's a coordinated movement. And then talking about their specialized equipment, again, we know ventilators, but also urinary catheters, trach tubes that hooks into the ventilator, colostomy tubes, and feeding tubes. So bariatric patients. With a bariatric patient, your book talks about obese is 30% over their ideal body weight. And then severe obesity is 2 to 3 times over their ideal body weight. So patients with obesity, we need to make sure that we can handle, protecting our backs, moving patients in coordinated movements, talk as a team, request additional resources if you can. And then we have specialized ambulances that deal with bariatric patients. And we dealt with that. We kind of went over that in lifting and moving in that chapter. We do have different types of assistive devices as well to help pick patients up that fall that are bariatric patients. Talk to the patient about how they normally move. Be very careful moving your patient by grabbing one limb or just trying to pull on them. You're going to hurt yourself and you'll hurt the patient. And then when we put the rails up on the gurneys, be careful that you're not catching skin, right? That can be pinch points for it. Make sure that they're buckled appropriately. And then think about how your gurney fits on the axle. If your gurney is sideways or set offset on the axle, set offset in the back of the ambulance, you put a really large patient back there, you change the center of gravity in the back of the ambulance. And so you've got to be very careful when you're taking turns that you're now off weight, and that turn can cause you to have an accident. And that can happen when you have a patient that's 600, 700 pounds in the back. All right, patients with obesity, we already know higher risk for DVTs. They can have bed sores, have a lot of other issues, can have problems being supine, have breathing difficulties when they're laying supine. It's also important to early notify the hospitals, the receiving facility, either in the pre-hospital setting or in the interfacility setting, to make sure that they're ready and equipped with things that can handle that patient size. Not all hospital beds are made to handle patients that are over about 300, 400 pounds. So they have to have specialized equipment in place. Tracheostomy tubes. So this is an airway tube, fits in the trachea. We showed stomas in chapter 13, all right? And that's just the little hole that's left here. The tracheostomy tube is where it has a plastic fitting and it has a flange. Now, trach tubes some of them can have this balloon at the distal end of it, the cuff. Some of them do not. They are easily dislodged. They do become irritated. They can get infected very easily. And patients can also have obstructions from mucus from the trachea. Most patients, when they have a tracheostomy tube, they're trained to suction and they have equipment to suction their tracheostomy tube. Now, know your scope. In Southern Arizona, we can't deep suction a patient. That's against our scope. Now, if I'm transporting a patient with an unrelated issue, right, they're not having an airway issue, and their trach tube becomes obstructed because there's mucus in there, my scope says I can't deep suction it, right? Common sense and reason says I'm going to suction and attempt to remove that object or that mucus plug. I can't just pull the trach out, all right? That's going to cause even more issues, and I can't deflate the cuff and all sorts of stuff. So we really need to make sure that we're thinking and we're using our critical thinking skills when we have a patient with a trach tube. The other thing with the trach tube that you need to realize is that it bypasses the mouth and the nose. So unlike a stoma when we're ventilating somebody with a stoma, we have to close their mouth and nose, right? With a trach, you don't have to do that. But if they have a trach, it'll be completely ineffective to try and put a bag valve mask on top of their face and ventilate them. It's not going to go anywhere. The tip of the trach has a fitting that fits onto your BVM. And then a lot of times some patients will have the trach just open and use it as an access point. Sometimes the trach will be already connected to a ventilator. All right, so they're prone to having those mucus plugs end up in the trach tube. Use the DOPE mnemonic. So when we talked about other equipment, we use the DOPE mnemonic, but when we have an equipment fail, all right, DOPE stands for displacement, all right, and then obstruction is the O, P is the patient. Did the patient wake up, come out of sedation, or there may be a pulmonary embolus, or maybe there is a pneumothorax that has occurred. Something going on with the patient, though, that's the big one. And then E is the equipment, all right? Is the equipment itself not working? Has it failed in some way, shape, or other? So I always start with equipment and I work my way back. But with the D, has that been displaced? And those trach tubes, a lot of times it can be easily displaced. All right, when in doubt though, we ventilate our patient. Same thing when we have a ventilator fail. Sometimes we get called to patients' homes. They're already on mechanical ventilators. Maybe they have to go to an appointment or whatever. Sometimes we transport for that. Or if it's an emergency call, they're on a ventilator at home. When they're on a ventilator, they're going to require ventilations when we're transporting them to assist with ventilations. If you don't have ventilator capabilities because you're a BLS unit, that's fine. We still have our hands, we still have a BVM, right? We still know how to provide rescue breaths for this patient. The weirdest part is that they're probably going to be looking at you while you're ventilating them. I've actually had patients ventilate themselves too. Apnea monitors are used for patients who have had what they call a near life-threatening event. They might have had a sibling that died from SIDS, sudden infant death syndrome, or have like severe reflux where it burns their airway, or there's risk for aspiration. So this monitor, when it goes off, it vibrates to try and shake the baby. It makes a noise to alert caregivers. Sometimes when it goes off, patients are trained, or patients' family members, I should say, are trained in what to do when the apnea monitor goes off. And part of what they're trained to do is call for 911. And apnea monitor actually, most of them have a recording device in it. So when we transport a patient that has an apnea monitor, bring it with you to the hospital. I would say don't even take it off the patient. ALS units, if they need to put their electrodes around it, that will be one of those indications they might move it, but we can usually place electrodes in different positions. Right. So yep, here we go. Sounds, if the alarm sounds if patient experiences bradycardia or apnea. Now patients' family members can get those, a pulse ox that sits on a monitor at home. They don't even need a doctor's prescription for it. And they have the baby monitors with the cameras that hook into everything. They've got all this fancy equipment going on. So, you might not have an apnea monitor per se, but you might have something where they had a near life-threatening event, or one of their pulse ox monitors went low and the family members call us. Internal pacemakers, I'm not going to get into a whole lot because we talked about it with chapter 13, and you've also talked about it in your CPR classes, hopefully. With the internal pacemakers or the cardiac pacemakers, like a deck of cards under the skin, sometimes they're smaller. The biggest thing is do not put the AED pads over the top of the pacemaker, right? And then LVADs. So LVADs have been around, I wouldn't say maybe 10 years. This is for patients who are, their ventricles, one or both of the ventricles have failed or are near failing, and they're going to need a heart transplant. And they're on the waiting list for heart transplants. And before we had LVADs, they would be put in the hospital. They would be prolonged hospitalization until a heart became available or until the patient died. This LVAD system allows them basically to go home with this mechanical system in place. It's a surgical system. They have to surgically go in and do open heart surgery and attach the LVAD. But when it's in place, it lets them go home while they're waiting. So they can go through their normal life as normal as you can. But it operates off of batteries. It's kind of this cool little box. And they basically just kind of hang out with it. First time I saw it, one of the guys rode his bike to the fire station to tell us about that he had an LVAD at his house. And where I was at in Green Valley, they're really good about keeping track of what homes might have things. And he explained to us what it is. And there's several different manufacturers for LVADs, and each one's slightly different. All of the LVADs have a number that you call, or you can call if the patient's in cardiac arrest or if something's going on with it. If we're transporting the patient though and they have an LVAD, all you need to do is take the LVAD with you, short of in the cardiac arrest. I will be putting a video into the drive about EMS and LVADs, and some of the case studies and research that's gone into LVADs and cardiac arrest and what we do. The biggest thing with LVADs is that you default to your medical direction. That's a big one, because if your medical direction, I mean, some of them want us to do CPR with the LVAD in place. Some of them want us to make sure we're ventilating the patient and just transporting them all with the LVAD. So make sure you know what your medical director wants you to do before you have the eventuality of somebody having a cardiac arrest with an LVAD in place. So here is one of the videos for LVADs. Should have switched the screens, I hope. Let me make sure. All right, cool. So it's a short video, and then I'll put the longer video into the drive for you.
Mechanical circulatory support introduces the HeartMate 2 left ventricular assist system. The HeartMate 2 is a small and quiet advanced blood pump designed for improved outcomes with a wide range of late-stage heart failure patients in need of reliable, long-term circulatory support. 60% smaller than currently approved implanted electric pulsatile LVADs and weighing only 400 grams, the HeartMate 2 incorporates precision engineering, a simple design, and 30 years of clinical experience. It is intended for long-term support as a bridge to transplant or for permanent implant known as destination therapy. The HeartMate 2 is implanted just below the heart. The flexible inflow cannula is attached to the apex of the left ventricle, and the outflow cannula is attached to the ascending aorta. The HeartMate 2 pumps blood from the weakened left ventricle to the aorta, the main artery feeding blood to the entire body. The flexible inflow cannula is designed for a wide range of patients, accommodating changes in anatomical position and allowing the inlet to remain centered in the ventricle. Both the inflow and outflow cannulae feature textured blood contacting surfaces clinically proven on the HeartMate XVE to be thrombo-resistant. Utilizing advanced continuous flow technology, the HeartMate 2 has only one moving part, a small spinning rotor that is capable of providing flow from 3 to 10 liters per minute, covering the full cardiac output of a healthy heart. As blood enters the pump, seen here in slow motion, it is straightened by the inlet stator veins prior to entering the path of the rotor. The rotor then spins the blood radially and propels it toward the outlet, where blood flow is straightened by the outlet stator veins. In typical operation, the pump runs from 8 to 10,000 RPM. The HeartMate 2's patented ball and cup bearings are designed for long-term reliability and the minimization of blood damage. Pump flow is defined by two factors, pump speed and the pressure difference across the pump. For a fixed pressure difference across the pump, increasing the pump speed will increase pump flow. At a fixed pump speed, decreasing the pressure difference across the pump will increase pump flow. The simulated monitor tracings show the ventricular and aortic pressures of a patient. The blue waveform represents the pressure at the pump inlet, which is the left ventricular or LV pressure. The red waveform represents the pressure at the pump outlet, which is the aortic pressure. The difference between these two pressures, indicated by the vertical yellow bar, is the pressure difference across the pump. As can be seen, this difference varies over the cardiac cycle, with the largest difference occurring in ventricular diastole and the smallest pressure difference occurring during ventricular systole. For a given pump speed, in this case 8,000 RPM, the differential pressure defines what the flow through the pump will be at any given moment. In other words, for the example shown, during cardiac systole, the blue waveform, LV pressure, rises and is essentially identical to the red waveform, aortic pressure, which results in a decrease in the differential pressure. This is shown by the yellow bar becoming shorter. As the pump inlet and outlet pressures become more equalized, it becomes easier for the pump to propel blood forward, and therefore pump flow increases. This is shown by the increase in flow on the green waveform. The reverse is true during diastole at the same pump speed, where the blue waveform, inlet pressure, and red waveform, outlet pressure, separate, shown by the yellow bar becoming taller. When this occurs, the differential pressure rises, and the pump must overcome this increased pressure difference between LV and aortic pressure in order to propel blood forward, and therefore flow decreases. A parameter that can be used to describe the magnitude of pulsatile flow across the pump, relating to the degree of ventricular contractility, is referred to as the pulsatility index, or PI. The higher the PI value, the greater the fluctuations in flow over the cardiac cycle. In this example, at 8,000 RPM, the PI is 5.7. For a given differential pressure, as the speed of the pump is increased, the flow through the pump increases and leads to greater ventricular unloading. As the pump performs more ventricular unloading, the left ventricle builds up less systolic pressure. This causes the blood flow pulsatility to decrease. This will be seen in the flatter pressure and flow curves as the pump speed is increased from 8,000 RPM to 10,000 RPM, with a corresponding decrease in the pulsatility index. As pump speed continues to increase and the left ventricle, external system components of the HeartMate 2 include a small, flexible percutaneous cable that provides power to the pump and is designed to accommodate patient activity, the system controller, which controls pump operation, and the batteries, which may be conveniently worn in holsters and enable the patient to resume normal daily activities. The HeartMate 2 also shares the same equipment platform as the HeartMate XVE, which includes the PBU, system monitor, and display module. The HeartMate 2 is designed for reliable, long-term support. It incorporates precision engineering and over 30 years of clinical experience. Its small size and silent, vibration-free operation make it appropriate for a wider range of patients than currently approved devices. Its reduced size also contributes to a simpler and considerably shorter surgical procedure. The HeartMate 2.
All right, so the big point I wanted you guys to see out of that one, switch this back, was that they come in different sizes. They make a noise, so people living with these, they'll constantly hear a noise with them. This one has pressure that changes with it, so a patient can sometimes have some discernible pulses with it, although most times don't expect them to have a pulse with it. So it's kind of weird when you've got somebody talking to you in front of you and they don't have a pulse. It's palpable. And it makes noises. It runs off of batteries. They get alerts when the batteries go low. So basically they're walking around, their heart's in a little box that's pumping for them, and that's what they're dependent upon for survival. But they have a better chance of survival out of a hospital setting than they do in a hospital setting where other things like infections can occur. All right, external defibrillator vest. I haven't seen one of these in forever. Basically, it's just a pads that attach with a vest to the patient's body. They hold it, wears it across theirs, like tightly fit across their body in like a tank top, and then they wear their clothes over the top of it. It allows for shocks to be given. It does sound an alarm when a shock's going to be given, and then we can provide CPR with it, depending on your medical direction, whether you take that off or not before you put on your AED pads. It's completely dependent on the medical direction, what you're going to do. I have not seen an external defibrillator vest in a very, very long time. Central venous catheters. So this is a catheter that's placed, it's a surgical insertion of a catheter, and they're surgically placed to fit into a large vein right? That goes a lot of times right into the atriums of the heart, or right into the right atrium of the heart. So people who have catheter replacements, shunt placements, or even dialysis port placements, those are things that we, one, don't want to mess with or break. The dialysis ports will be in their arms, so when we're taking blood pressure over it, that can cause some problems with it. But we also aren't allowed to access them at all. They're capped. So we could transport a patient that has one of these, but we cannot transport it if anything is running through them. It's not abnormal to have blood in the line to it as long as it's capped off, right? They're usually heparinized, meaning that there's a medication in the line that's called heparin and it keeps the blood from clotting. So they have to reheparinize it before they are able to close off that cap. They can become dislodged and it can create a real problem. Obviously, the patient can bleed quite profusely. I've seen them when they remove it and it's just this nice long piece of tubing that comes out, but they can break as well. Say a seatbelt catches it or something else catches it and they break and they're gonna bleed profusely. It's not like you can put a tourniquet right here on that patient, holding pressure. You're gonna hold pressure on a somewhat firm piece of tubing to try and keep it from bleeding. I heard of a cop using QuikClot on one it was up in the arm and they were able to save the patient's life that way. But broken venous central catheter is a real emergency, but we just don't mess with them. All right, G-tubes. So G-tubes are used for patients that can't swallow for one reason or another. So they're unable to take medications, fluids, whatever orally, or maybe they're unable to take certain, they can only take certain amounts or small amounts of food or liquids orally. So they're placed in the abdomen, right? And it's got like a little top here, and that's how they eat. So liquid food is poured in through it. Sometimes there's different types of suspensions that they push into it. Cornstarch is one of one when they want somebody to gain weight. So when you've got a patient that you're transporting with a G-tube, they do bleed around the site. They have a high risk of infection around the site, so they have to be very careful. Obviously, you don't want seatbelts and things like that sitting over the top of it, but they have a high risk for aspiration. So make sure that you keep their head elevated, especially if they've just had fluids placed into their G-tube. Patients with shunts. So patients who have different disorders that build up a large amount of intracranial pressure due to increased CSF, they'll have a shunt that goes up into what we call a ventricle of the brain, which is the spacing inside the brain. Sometimes the shunt sits right at the base of the head too, and it drains off the fluid, the extra CSF, drains down. The shunt's placed under the skin, right? And you actually palpate the shunts in the neck down, and a lot of times it drains into the peritoneal cavity. And so it reabsorbs into the body that way. The shunts can become infected. They can become obstructed. So there's a lot of risk with having a shunt. Patient who has a shunt that has become obstructed for one reason or another, they will have a severe headache. They're going to run a really high fever. So it's going to present very similar to meningitis. And then if somebody's been monitoring over a period of time their pulse pressures, as that pressure increases in their brain, the pulse pressures are going to get wider and wider. So they'll start here, and the difference between the systolic and diastolic will widen out significantly. Vagus nerve stimulators. So vagus nerve stimulator, it looks like a little coin under the skin, and it sits there and it's used in conjunction with medications to control patients who have seizure disorders. So that stimulator can go off and it helps control when they have seizures. Some of them are like this constant, or it's a pattern of electricity to the vagus nerve. The biggest thing is don't put anything over it like an AED pad. That's a big one. Colostomy and ileostomy tubes. So patients who have colostomy bags or an ileostomy, it just depends on what part of their intestines were obstructed or damaged for one reason or another. And they had to go in, and so that the patient could eliminate waste, they had to create an external port, right, for that patient to, it's called a stoma, even though it's down in their abdomen, it's basically a hole into the body. And through that stoma, they eliminate their waste into a bag that sticks onto their skin. There's a lot of reasons why somebody could have had a stoma or a G2, or sorry, colostomy or ileostomy placed. The bags can become dislodged, which creates a mess in the back. Patient can also become severely dehydrated, depending on where that ostomy is at. And they can get infected around the stoma. You think about it's bile and icky stuff, stool that's passing out of that bag, and it's coming in contact with the outside skin. So there's a lot of cleaning that goes into making sure that those stay clean and stay healthy, so that the skin and the tissue around it doesn't start breaking down. All right, signs of infection, again, pain at the stoma site, and fever, discoloration. Those are all signs of infection. Just be very careful, because those bags do become dislodged, and you will not be happy as soon as that stoma becomes dislodged. And then some people have urostomy, which is where they have a stoma, and instead of having catheters all the time, they put a stoma up above the pubis, and allows for urine to drain directly out of the bladder. Right, so the biggest thing is asking what's different today, what's going on today. You could be there for a completely unrelated issue, and they have any of these kind of what we call challenges, but any of these sort of assistive devices or other things that are part of their normal daily routine. So it's important to assess what's new, what's happening today, and then take into account what they have going on and what their past medical history is with regards to some of these situations. We talked about already patients who have home care, home health. Sometimes they're lucky and they have the same healthcare provider all the time. Sometimes it's different people depending on the agency that they might use that are in that house. But always look for where they keep the notes, because the notes, again, help you do your detective work. Paint a picture, what medications this patient's been on, what's been going on lately with this patient. Look through those notes to find out, what's changed today, help establish baselines, things like that. Right, and then terminally ill patients, patients with DNR, home hospice, or patients that want to go home, if they're terminally ill. Just remember that if somebody has a DNR, it does not mean do not treat that patient. DNRs can be overturned, family members. We do get called for patients that go into cardiac arrest with their DNR, because they have to have a medical provider pronounce it. There are times where they are instructed to call home hospice, and we're not involved in it at all. But remember, for us to honor the DNR in Arizona, it needs to be on that orange sheet of paper. It needs to be their original. It needs to show a description or a picture of that patient, and it needs to be signed by a licensed healthcare provider. Palliative care is when people who are basically in the last few days of their life, they're given medication to make them comfortable so that they can die either at home or in a care facility. And it's medication strictly to make them comfortable. So if they're under palliative care, there's usually for DNR and patients that are on home hospice, those patients are educated, the families are educated by the medical team that is taking care of that patient. But just remember, you go back to all those things that can happen on a scene. Talk about your medical legal chapter. You need to review that again when we're talking about patients who are on home hospice. All right, follow your protocols, and then find out what your patient's family wants, but also what the patient wants if they're still talking to you. Do not treat or do not resuscitate does not mean do not treat, okay? Ask them if there's a plan in place if something happens, if they get sick, are they supposed to call somebody? Most home hospice, the good agencies, will have 24 hours a day, have somebody available as well for the family to call for help or for questions with medical concerns, or for us to call. All right, poverty and the homeless. The biggest thing in Tucson, our homeless population doubles in the winter due to the climate here. So that's something we need to consider. We need to make sure we're patient advocates no matter what. And it's going on with our patient, whether they live in a mansion or they live on the side of the road. So that's a big thing we consider. Also, don't assume that you know the reason that that patient's homeless. People become homeless for a variety of reasons. And I think that even with this pandemic going on, we realize how close some of us or some people or your friends could be to being homeless that easily. So those are things that we need to consider. We want to treat patients with respect and dignity. We do see in the homeless population, which is unfortunate. First of all, a large population of homeless people are also veterans. So knowing what kind of resources might be available is really important. But we do see a large population of homeless people who have substance abuse issues or mental health issues. And of course, if we're being called to the scene, it's not like they're every day. It's because something's going on, and you're being called there for a specific reason. So we tend to see the worst of the worst of patients who are homeless, but that does by no means represent all patients that are homeless. So we treat everybody with respect and dignity, become an advocate for that patient, and then knowing what services are available in your area is also helpful. Any knowledge base you have above and beyond that, you're being a patient advocate at that point. And our entire job is, again, treat our patient, be a detective, continuity of care, but advocacy. Advocacy for our patients is very, very important. It's something I take seriously. Anytime I can learn from a patient, regardless of what's going on, I take that opportunity to do so. And same thing when patients, I'm transporting patients, even psych patients, homeless people, I ask their story. I've got time in the ambulance when we're transporting. I ask them to tell me their story. It's just another way you can connect with people and find some common ground with people. It also helps keep you from getting so burned out, and it gives you a better knowledge base. It makes you a better provider the better you educate yourself. So that's my 2 cents on all of this. Make sure that you come to class when you're coming into the Q&A sessions, having read the chapters, watching the lectures. So if you're at this point in the lecture, you should have watched it all. Come with questions, or if there's anything you want to get into more detail about in class, and we'd be more than happy to do that with you. Again, get your chapter quizzes done. If you have questions on any of those quizzes, let us know. Make sure you're communicating with us, because the only way we know if you're having problems is if you're talking to us and letting us know. All right, off to the next lecture.